The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, an apparently lazy psychiatrist is called out.
Because of the heavy-handed approach, it's forced the issue into a litigious framework.
That's Dr. Leigh Haysom, the Clinical Director of Adolescent Health and Director of Medical Services for Justice Health and Forensic Mental Health Network in New South Wales. And I'm presenting her with a difficult scenario.
In these sorts of situations, the staff can sometimes take shortcuts in patient care to avoid dealing with a difficult and a confrontational doctor.
In today's scenario, a staff specialist psychiatrist has attracted multiple complaints over several years relating to late arrivals, early departures from work, difficulties contacting them when on duty but not on site, and being rude and aggressive towards junior staff. The clinical decisions appear appropriate. When complaints are reported to the Clinical Director for Mental Health, they make excuses for the doctor, gaslighting staff for complaining and avoiding any kind of confrontation. In frustration, the nursing staff have escalated their concerns to HR without consultation with management. To prove a case against the doctor, HR have accessed biometric data from the software vendor. This is primarily used for staff identification and access to the secure unit. The information is compared to his timesheets, and formal written allegations of misconduct are provided to the doctor. Both parties have escalated the case to their lawyers. I started by asking Dr. Leigh Haysom what general concerns this scenario raises.
I think the concerning aspect of this scenario is the problem created through a lack of early management of poor performance by the doctor, which has led to an escalation and a sledgehammer response from the organisation by confronting this doctor with audits of his timesheets and biometric entry and exit data from the mental health unit. And this sort of heavy reactionary response usually springs from a place of organisational and staff frustration, which an earlier performance management approach could really have avoided.
Needless to say, psychiatrists are a very scarce resource. Your organisation doesn't want to lose the psychiatrist, but on the other hand, it can't continue with this poor performance. What are the issues then that you see that need to be addressed?
Yes, well, if we were able to take a step back and reflect on a better and an earlier response to the issues, then clearly the poor performance of the doctor in terms of his attendance, being available and his communication style needs to be addressed. Fortunately, we aren't dealing with direct patient care concerns or incidents, but in these sorts of situations, the staff can sometimes take shortcuts in patient care to avoid dealing with a difficult and a confrontational doctor. For example, leaving matters of concern about clinical care for the registrar or even for the next shift of doctors. And this could eventually result in a patient safety concern. The other elephant in the room with regard to this situation is the lack of response from the doctor's direct line manager, who's the clinical director, who's received a number of complaints from staff over a long period of time. And he's chosen to look the other way. And this is also a performance issue and it needs to be explored and to be remedied. The other concern is that the staff in speaking up for safety, which we'd obviously want to encourage, are not being adequately acknowledged and addressed. So this leads to this culture of frustration and mutual disrespect between the clinic staff and the management staff. And it forces workarounds and escalation to other parties in order for those staff to be heard. And this often takes matters into an entirely different direction, and it's hard to turn that decision around. And I think the final issue for this scenario, David, is that the reflexive response by HR to address the doctor's underperformance by really resorting to a path of least resistance that's not aligned with a just and restorative response to these sorts of matters, relying on timesheet biometrical data to really corner the doctor. This is really an overreach response to these concerns.
You've got a real dilemma. Let's start with, what are some of the outcomes that you are aiming for once this has been resolved?
Yeah, so if there was an opportunity to intervene in a more just and restorative way before this ended up with the lawyers, my goals would be that the doctor has a clear understanding of his expectations of his role, of his hours of attendance, his availability, and being mutually respectful in the workplace with regards to his behaviours and communication style. I'd also be wanting the clinical director to understand his obligations as a manager and to feel supported by his own line manager and by the Director of Medical Services in his capacity in managing this problematic staff member. I'd be wanting the staff to feel acknowledged and listened to when they're raising concerns, when they're speaking up for safety, and understand the better pathways for escalation of medical matters, and that this would hopefully lead to a more just management of the issues. And because there's been a breakdown, obviously, in the communication between HR and medical management, leading to them resorting to a heavy-handed response to resolve the long-standing performance issues, I would hope for better pathways of communication between HR and the medical management.
That's a big list. Where do you start?
Well, I think I need to identify who are the stakeholders in this situation and what are the stakeholder relationships. And because the performance issues have been poorly addressed over a number of years, there are now a number of parties involved who are all stakeholders in the relationship. So there's the doctor himself, there's the clinical director, there's myself, there's the DMS, there are the staff with whom the doctor works, there's the HR department, and unfortunately, there's now the legal teams on either side. And in the bigger picture sense to all of this, there are the patients at the centre of the stakeholder group, and it's their safety in these matters that's really first and foremost.
So what are the likely risks, perspective and concerns of each of these stakeholder groups?
Yeah, sure. So there are a number of risks relating to these concerns. Obviously, the staff feel frustrated and harassed when they can't contact the doctor or he's barking at them from the end of the line. And this leads to those workarounds and shortcuts, which could potentially lead to a patient safety issue. And that's obviously of primary concern. By not setting clear performance expectations for this doctor, it also allows that bad behaviour to perpetuate. And this makes it very difficult to address the longer it's enabled. And inevitably, it then pushes management into a different pathway of managing that behaviour, and this can lead to what we saw, which was a more heavy-handed management style. And once the matter escalates into that legal space, it comes to the attention of the executive, who consider the whole situation to be poorly managed by everyone and messy, and this reflects badly on everyone's reputation at the end of the day.
So can we explore what actions you're going to take? What are the first things you would do? Who would you meet with? How would you go about trying to de-escalate what's now a potential crisis?
I think the first step would obviously be to meet with the clinical director to discuss the issues about the doctor, but also to explore the reasons for their own poor performance in not addressing the matters in a more timely way. And that conversation would need to rule out any potential conflict of interest that may exist between the two staff members in terms of, say, friendships or a working relationship. So in my organisation, which is quite a small organisation, we often have staff who are friendly outside of work and who have important working relationships outside of our organisation. And this obviously would need to be addressed and managed. I think the next step would be for the clinical director to develop some skills in managing those difficult conversations, setting boundaries, performance management of problematic staff. And he should be aware of seeking support in a timely way from the Director of Medical Services and their own line manager with regards to these sorts of situations. So that may need a coaching approach or opportunities for developing skills in mastering difficult conversations. With the clinical director, I would be wanting to very early on draft a plan of approach that involves a meeting between the clinical director and the doctor to discuss the issues around the attendants being available and their communication style. And this meeting would obviously need to clearly outline the expectations of the hours of work, being contactable when they're not on site, and reflecting on the organisational codes of conduct around respectful behaviours and communicating with staff. The doctor, I think, should also be provided with an opportunity to speak about the issues of concern, because there are always two sides to a story, and to raise any of his own concerns about any of the matters. He may have his own personal issues going on at home that are pulling him away from his duties. And there could be even more concerning issues to do with the doctor around, for instance, substance use or mental health issues, which would obviously need to be managed along a different pathway, say an impairment pathway in that situation. I think after agreeing with the doctor about the expectations of the role, there needs to be a discussion about how performance should be monitored moving forward. That obviously needs to be part of that conversation. And this would involve the clinical director touching base with both the ward staff and the doctor going forward at regular intervals about attendance and communication and any issues that arise. I also believe that in that meeting, the clinical director and the doctor should agree on a future performance review meeting, say in another 4 to 6 weeks, and we should be booking that meeting in. And this would be at the end of a period of monitoring whereby the issues could be reviewed and any improvements can be documented on their performance development review. I also think the staff on the ward at this stage need to be reassured as early as possible that the matter's being managed in an appropriate way, and that the process for reporting future performance issues should really be clarified with them, so that this follows a more sensible line management process of reporting about any future issues, and that this gives the opportunity for the clinical director to intervene early with the doctor. Just lastly, with regards to the legal involvement, if the action sort of just described can steer matters away from that legal pathway, then that's really, really great. And HR may be willing to withdraw their allegations of misconduct against the doctor and allow a more restorative approach. Obviously, the executive and the MCCC committee, as we've discussed, would need reassurance of how the issues will be alternatively addressed, with a brief outline of the management plan and a risk assessment plan and a timeline of how it will be monitored.
Can we pick up on this idea about HR withdrawing their allegations? They may have become involved at the instigation or instruction of the chief executive because it was seen that this was an important issue, and yet the doctor requires an apology from HR. How do you bridge this gap between HR maintaining their credibility and yet the doctor requiring an apology for what HR think they've done an appropriate job on?
Look, it's a very difficult situation, isn't it? And to be honest, in my experience, that's never happened. Really, once HR's gone down a particular path, and they may have already sent formal letters regarding allegations, and the doctor has engaged their own legal team, it becomes difficult to turn that ship around, to be sure. And often those sorts of conversations and that reversal happens behind closed doors, and it usually doesn't involve me, unfortunately. But look, in the situation where it hadn't gone to that level of engagement and we were in a situation where things could be pulled back a little, I do believe the doctor needs an apology about any misuse of information and some assurance that would not occur again. I think in that instance, there are often reservations to admit that sort of liability because it often just leads to more litigation. But an apology would be a good start, and some assurance about how the monitoring would be conducted going forward in a more just and respectful way. However, it doesn't obviate the need to address the ongoing performance issues.
The other issue you raised is briefing up, keeping the executive appraised. You mentioned earlier that this may all have come about because the chief executive in some ways has lost confidence in your ability to manage medical staff. How do you go about repairing that relationship and rebuilding the chief executive's confidence in your ability?
I think keeping good channels of communication and informing the chief executive of any issues very early is a good approach in these situations. Having a very robust and safe response in terms of considering all of the risks that are involved with doctors who are not performing adequately, documenting those in a risk assessment template and doing that as early as possible, updating the risk assessment as time goes on, which will outline very clearly the ways that you're going to address those risks and the plan for management moving forward. Keeping the discussions within a structured framework and timeline so that there is ongoing updates to the chief executive through that performance management framework. So there's reassurance that things are being addressed and having regular reviews of the doctor moving forward and updating their own performance management review as part of that process.
One of the other areas you raised is keeping the staff informed. How much can you tell the staff about the work that you're doing, particularly if it reveals that there is compromise in the doctor's mental health?
Yeah, sure. So the staff obviously need to be told that there's a problem. They don't need to understand the details of that issue, but clearly they are the people who've been witness to the underperformance and to the issues, and likely they're the ones who've raised some of the allegations about the doctor. But they do need to have an understanding of the fact that an issue has been acknowledged, that there is currently a response underway that is appropriate to those issues in addressing those issues. They can be told about an approximate time frame for the address of those issues. They need to also be assured that there will be some backfill for the doctor and how any gap in the staffing will be addressed. And they need to be aware of how to escalate any concerns going forward about the doctor.
We mentioned earlier the focus on patient safety or patient-centred care. What evidence would you be looking for to be assured that the doctor is actually making good and appropriate clinical decisions?
Yes, so that's obviously a very important part of all of this, and we've taken it by verbal report from the staff and the clinical director that they're not aware of any significant patient safety issues, and you would hope that anything like that had already been escalated through the incident review pathway and any other issues to do with patients. However, I think in this instance, given that it's been going on for a very long period of time and that we have evidence that the staff are making shortcuts in terms of cutting this doctor out of the clinical care pathway in order not to have to engage with him, it would be worth the clinical director having a review of some of the patient records, perhaps reviewing some of the more recent patient incident reports through the Directorate Clinical Governance Committee, just to find some assurity that there's no intersection with patient safety issues and this doctor not being available or having an alternative care plan from another doctor who doesn't necessarily know the patient as well as the doctor who's meant to be on duty does. And I think that would be a really good thing to do in terms of just getting some confidence around the work of this doctor, particularly looking at patients on the days that he has been on duty and there have been some reports of not being in attendance or not being able to be contacted on those days.
At what point do you ask for expert advice, bringing in an expert to help you in this situation?
I think if the doctor is willing and open to the advice that has been given and is willing to engage with the performance plan and the monitoring plan going forward and the issues settle down, then well and good. Obviously, he needs to be involved in a regular performance management review going forward. I think if he's particularly hostile during the meeting, he's not able to reflect on the issues, he's unwilling to engage in the performance agreement, that would be a time to involve HR, I think, in the matter, to have them as that third party in terms of perhaps engaging in a more thorough investigation of the matters so that a formal disciplinary process can be undertaken. With regards to the legal concerns, I would certainly be talking to my legal representation with regards to my concerns about the use of the biometric data in this way, given that it wasn't intended to be used in that way. And it's obviously going to be an issue for the doctor's legal representation to consider when the matters do, if they go to the Industrial Relations Commission. And certainly our legal team may want to discuss with our insurer in that regards and give them a heads up about what might be lying ahead with that.
The ultimate sanction, I guess, in cases like this is reporting to AHPRA and the medical regulator. What would be the criteria that would trigger you to notify AHPRA that there was a concern about this practitioner?
Look, I think, David, if the behaviour continued despite attempts to address it through a restorative framework, and a notification to the HCCC would always be on the agenda at that stage. I think at this point we'd be involved with the organisational's MCCC committee. They would likely need to be aware of the issues if they weren't already aware, and they would have that assurance through a risk assessment and management plan. And that decision about notification to the HCCC could also come from the MCCC committee. Certainly if the performance hadn't improved or if it had led to a patient safety concern, a clinical incident concern, that would definitely be a reason to involve the HCCC and consider taking on a more assertive disciplinary action.
The focus so much on coaching, assuming that the clinician is open and willing to correct their behaviour rather than policing and chasing them down for inappropriate actions. Any final thoughts that you'd like to share with us in this difficult situation?
Look, I think the salient points for me are to acknowledge staff concerns early and demonstrate an appropriate response, to take action on the issues early with the doctor, and obviously in this instance with the clinical director, and to have a clear performance pathway and monitoring plan going forward that provides reassurance to the staff and to the executive that the appropriate action is being taken.
Excellent. Thanks very much, Leigh, for your help on this one. That was Dr. Leigh Haysom, the Clinical Director of Adolescent Health and Director of Medical Services for Justice Health and Forensic Mental Health Network in New South Wales. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.